going to look at the psychosocial aspects, the psychological, psychiatric aspects of disaster. And in a moment, when I go through the slides, the first 5 slides that you will see are different pictorial representations of different types of disasters. So we'll go through those. Then the next slide will be the paradigm slide. And I know you all have seen the paradigm slide over and over and over again today. So we'll see it. Then we'll move in to different psychological, psychiatric responses to the disaster situation. It is important to keep in mind that when we are looking at a disaster, we have individuals who are the quote-unquote identified victims, and then we have individuals who are the volunteers to help in treating victims of the disaster. It is important to keep in mind that with regard to sequelae of disasters, the individuals who participate, who volunteer to assist, can also become subject to the same type of symptoms that a disaster can cause. So we know that whether it is a chemical agent, whether, as we just saw through Dr. Theobald's lecture, or whether it is a biological agent, individuals who go to the site to treat are just as subject to being exposed to those agents. With psychiatric issues, individuals typically do not have any kind of biohazard outfit that they can wear to protect them from what's going on. So individuals who present to that site can be overwhelmed by the stressors with which they are confronted, and we can see adjustment disorders and other types of psychological disturbances in the individuals who present as volunteers. We know that disasters have a dramatic impact on the environment, and in fact they can have a dramatic impact financially. And so that's something that we keep in mind. The financial impact can take resources and absolutely destroy them. What we're going to talk about now in our slides is the impact that it has on individuals internally, their psyche, the psychological impact that we're going to see. Now again, when we look at these, and of course this slide's a little old now, however, it represents the fact that there is terrorism that can create disasters, and there are agents of terrorism. There are individuals who seek to create situations that will traumatize others. And then we can see these types of naturally occurring disasters. We can see equipment that goes awry. And we can see individuals injured in this type of a disaster. It may be created by others as an act of terrorism. It may just be equipment failure or human error. And then we can see naturally occurring disasters, hurricanes, tornadoes. How well we know, because it wasn't that long ago that tornadoes struck here in Kirksville, Missouri. And it wasn't that long ago that tornadoes struck here in Missouri in Joplin, doing extreme damage, both to the physical surrounding as well as to the internal environment within the individuals. And then, of course, earthquakes we have to worry about, and other types of natural disasters. Flooding, we see this quite a bit. This, again, is the paradigm. You all have seen this, I think, with every presentation. And when you look at this paradigm, what you're reminded, the word disaster reminds us, number one, to detect the prevalence of events, to anticipate resources, meaning, what do we have to be ready? How do we prepare for disasters? And then incident management. Once the disaster occurs, how do we manage this disaster? Safety and security. How do we keep the victims of the disaster safe and secure? And how do we maintain safety and security for the providers, the healthcare providers, the responders, the volunteers? Assessment of psychological hazards. That's us. That's what this lecture is about. This is where volunteers enter into the arena, and it's important to keep in mind that when it comes to truly treating psychological and psychiatric disorders, we need true professionals, well-trained, with understanding to diagnose and to intervene and treat. Support from state and federal assets, that's always important. Having the funds, the financial resources to be able to implement the programs. Triage. We need to be able to divide those individuals who need immediate care, those who are going to need care down the road, and those individuals who are going to need long-term care. We have to be able to triage the individuals. Evacuation and disposition, we have to know how to move people from the site and where to send them once we do. And recovery and resilience. We have to understand how individuals recover, how long it takes for them to recover, and what we can do to provide them the skills to be resilient in their recovery and perhaps to avoid future adverse impact from other emergency situations and disasters that occur. Protection. You'll notice in this slide, you see the three overlapping, intersecting circles. You'll notice there are distress responses, behavioral changes, and psychiatric illness. What is the difference in these three? And it will determine how we're going to intervene and treat. You'll notice when it comes to the distress responses, the two key elements here are insomnia and the sense of vulnerability. When we talk about psychiatric disturbance, we know that individuals are going to have sleep disturbances. Number one, the trauma is going to adversely impact their ability to sleep. And number two, it may adversely impact their ability to sleep from this moment forward for an undetermined amount of time. The same impact can occur to the volunteers. So we have to be aware of that. We have to talk to individuals about that. We have to ask them questions about it. And then when we look at this sense of vulnerability, individuals now no longer feel as if they are invincible. Now their world has been turned upside down. Now all of a sudden their sense of self-worth, self-value, self-esteem has been adversely impacted. We need to be aware of that. We need to address it when we're talking with individuals who are victims of a disaster situation. Let's look a moment at the behavioral changes. What happens in behavioral changes? Individuals change their travel patterns now. Some individuals may be afraid to travel into areas that are now considered to be high flood areas, high tornado areas, high hurricane areas. Individuals now may avoid certain vacation sites that they once would have enjoyed. Then we get to the psychiatric illnesses. The key ones that we're going to look at are going to be post-traumatic stress disorder and its mini-me sibling of acute stress disorder. We'll look at those. Major depressive disorder. Where does major depressive disorder come from? The loss of loved ones in a disaster. And for the individual, him or herself, they may experience an adjustment disorder. Those of you who have, with whom I've had the pleasure of presenting psychiatry here in the second year. An adjustment disorder is a response to a readily identifiable psychosocial stressor within the past 3 months that used to be said to resolve within 6 months. We now know there is a chronic modifier, so individuals may persist for a long period of time with this adjustment disorder, having a difficult time adjusting to the changes that have been caused and created by this disaster. Some individuals will move from an adjustment disorder into a major depressive episode and a major depressive disorder. The difference is the adjustment disorder has fewer adverse impacts in the 6 neurovegetative functioning inventory indices of sleep, appetite, memory, concentration, energy, libido, wherein in a major depressive episode, major depressive disorder, we see much more disturbance in sleep, appetite, memory, concentration, energy, libido, loss of interest in life activities, anhedonia. We see individuals who now also are ambivalent about living. They may even have suicidal ideations. They may want to die. They may even engage in self-injurious behaviors. They may have lost a sense of self-value and self-worth, and so we see a loss of self-esteem. The magnitude of the problem. When we look at this, we can see from this slide transient distress symptoms. Over 50% of the individuals who experience a disaster will have transient symptoms. The symptoms will dissipate over a certain period of time. Behavior changes, substance abuse, we're going to see, depending on the magnitude of the problem, we may see individuals now, 10 to 25%, according to these statistics, up to 1 out of 4, will now experience changes in behavior, as well as may engage in the use of substances. Now, because it says substance abuse, it doesn't mean that it's necessarily an illicit substance. So what are the legal substances when we see individuals use it? Well, number one, alcohol and tobacco products, and we know that those who are over the age of 21, alcohol is a legal substance, and in fact it is used to calm anxiety, and it may even be used to induce sleep, and it may be used to deal with depression. It doesn't mean it's the way to go.